Alright, today Ankara, Ashley, and I will be presenting our PowerPoint about a PowerPoint with the question: to what extent does socioeconomic status limit mental health treatment access? And I will be presenting from an economic perspective, Ankara will be presenting from a scientific perspective, and Ashley will be presenting from a social perspective.
What led to our question, ongoing debate for our question, is that is socioeconomic status a real problem correlated to mental health? Many don't believe that the difference in socioeconomic status affect this or have any correlation to it. The other ongoing debate for this is that the treatment access is fair across all different socioeconomic statuses, meaning that regardless of what's going on, everyone has equal opportunity to receive it. The stimuli we used was The Science of Genius by Dean Keith Simonton, who has a PhD in psychology. He implied that people with a higher intelligence among all socioeconomic statuses suffer equally from different mental health issues. And a study by Ellen Bielstock, PhD in psychology as well, in Mapping the Bilingual Brain, a radio interview performed by Chris Beru, implies that bilingualism may be a potential solution to help combat brain-related mental illnesses and such.
Economic perspective, limited availability of mental health treatments. In a study conducted by Rachel Garfield, PhD, Health Policies and colleagues, they found that 37% of working age adults were uninsured at least part of the year, compared to about 20% without severe mental illness. And between 1999 and 2009, the share of firms offering mental health coverage declined from 59% to 56%, and the share of workers with employer-sponsored coverage declined from 69% to 61%. And human capital concerns. Over the period between 2011 and 2030, an estimated $16.3 trillion is estimated to be lost globally in this, and the World Economic Forum, in a study conducted by Bloom and colleagues, found that the global cost of mental illness was an estimated $2.5 trillion in 2010 and is expected to rise to $6 trillion by 2030. The inefficiency of healthcare. People with mental illnesses frequently report the frustrations of delivering healthcare, such as long wait lines and mistreatment by mental health workers. And between 1997 to 1998, 10.9% of the population perceived the need for mental health treatment, with 50% obtaining no treatment, and 11% experienced delays obtaining less care than needed, in a study conducted by Sturm and Sherborne, PhD psychology. And according to my graph, so it shows that socioeconomic status does impact the availability of mental health treatment because Caucasians are more likely to have access to mental health treatment versus minorities. And while some believe that limited availability is not a major factor when determining lack of mental health treatment in communities of lower socioeconomic status, a survey conducted by Andrade, Alonso, and Kessler found that only 12.4% of those surveyed said availability was the reason that they did not access any mental health treatment. But economic analysis of patterns of use of mental health services indicate that it's impacted by prices. Use falls when costs rise, and while use increases with better insurance coverage. In a study found by Manning and colleagues, and the demand for mental health services is more responsive to price than demand. More responsive to demand Then other types of health services, Taub and Goldsmith. Solution would be to increase the availability of mental health care by removing economic barriers preventing persons from access to mental health care. Barriers such as structural barriers, which is like the location of mental health treatment that makes it difficult for persons of lower socioeconomic status to access the areas. And barriers such as price or such as cost, which would make them unable to afford healthcare.
All right, so my perspective covers the link between accessibility to treatment and socioeconomic status. So one thing I noticed from my research was that educational gaps tend to lead to misinformation between parents and pediatricians. Depending on the level of interest the pediatricians have and the education they have on the mental illness treatment, the pediatricians may or may not inform parents on where to get treatment. And another factor that plays in there is that parents, according to Stacy Hodgkin, PhD, her studies concluded that parents often do not seek mental health treatment from rural and poorer regions to avoid being labeled insane. So parents of low SES typically go in 3 phases with their children: the individual level, the social level, and the community level. The individual level is the interaction between the child and the parent, and depending on the parent's socioeconomic status and the neighborhood and position of choice, the child's life could either be influenced with wealth and proper coverage, or they could be suffering from substance abuse. The social level is how the child interacts with the rest of his community. It is impacted by the neighborhood and the crime organization within it. And the community level is the community environment chosen by the parent to settle in. And Dan Hurley, an NY Times journalist, takes note of this, that kids in Chicago Heights, a less socioeconomic and less socioeconomic status rate and higher crime rate, has a typical 16% graduation rate from high school. So misinformation can happen when the pediatrician does not take an interest in the parents' problems, because parents are most often connect to their pediatrician as their first source of mental health treatment. And Hodgkinson and Dean Simonton believe that depending on how the patients present themselves to their caretakers, the caretakers may not report them to mental health treatment, or they may give them other benefits. So my counter argument to this is that mental illnesses are correlated with wealth. Wealth, according to Christopher Hudson, he believes due to a 1980 study out of 21 cases, which 19 out of 21 cases showed an increase in unemployment and decrease in seeking of mental health therapy. And another counter argument is that drugs can be used to account for mental illnesses, as 40% of Americans take them. Counter argument, my rebuttal to this is that there is Edith Parker, PhD in psychology, notes 2 main factors of socioeconomic status and the movement of mental health. One of them social selection and the other one social causation. And she notes that they have an equal impact on the movement and occupation of the parents, as well as their behavior and connection with the family. And this is a diagram of how social causation relates to mental illness and social selection to social care. Social causation takes more of a social side to this argument, because it refers to the interaction between the family and the patient. Social selection focuses on the employment side of whether whether the employer covers for their mental illness treatment and whether they can afford it. And my conclusion is that pinpointing individual neighborhoods by connecting the federal government to communities will encourage rehabilitation and mental illness treatment programs and patient-centered medical homes. Yeah, patient-centered medical homes is a system where the parent can bring their child to the pediatrician. The pediatrician refers the child to the mental health treatment facility, and the parents can have regular contact with the caretaker and the child to improve relations and learn better parenting techniques. All right, Ashley.
Socially, I looked at the effects of social stigma on access to mental health treatment. If mental disturbances are in the mind but not the body, they may not seem real, says Mary McKay, PhD in Poverty and Policy Studies. This implies that the stigma may deter treatment and diagnosis, which may lead to misinformation on the urgency of the issue. Rates of mental care, of course. People in lower socioeconomic conditions tend to correlate with higher rates of mental illness, says Deanna Scarpano, who has a PhD in English analysis through her analysis of young adult novels. It's supported by the previously mentioned Rachel Garfield's study into how lower socioeconomic conditions correlate with this rate. Barbara J. Byrne, PhD in psychiatry, also states that in a study by her states that 1/4 of youth in lower socioeconomic statuses up on welfare systems do not, only 1/4 of them have access to treatment. The graphic shown shows that 21 of the respondents polled in April 2016 who could not afford this care, shows that 13% of them couldn't afford the cost and another 12% couldn't afford it because of their insurance, which both correlate economically to this issue. The social stigma shows that 10% were too afraid or embarrassed to seek care, and 8% didn't know where to get the care, which is due to a spread of misinformation on the topic. To combat these, an increase in awareness via media campaigns to combat the stigma will lead to lower stigma and an increase in awareness, more diagnosis, funding, and campaigning for better treatment due to this.
All right, so our solution to this problem is to increase the number of participation in the mental health workforce. And some action was taken towards this, such as the president taking at least $500 million out of his fiscal 2017 budget to increase the number of states participating in the behavioral health program, provide better scholarships and grants to mental health professionals, and increase awareness to prevent suicide. The problems with this solution is that workers are underpaid according to SAMHSA, the Substance Abuse and Mental Health Administration, as a 2012 report shows that 18.5% of addiction professionals had turned over or quit their jobs. And another study conducted shows that in more impoverished areas, at least 33.2% of counselors and 23.4% of supervisors have chosen to quit their jobs. So if more awareness was brought to this problem, the solution would be more effective. And the turnover rate for the medical field is significantly lower compared to the mental health field, as physicians have a turnover rate of 7.1%, whereas psychologists tend to have a turnover rate of 19.3%. And part of this problem is due to the low wages paid to these workers. A social worker is paid 45K max and 30,000 minimum, and a general care worker is paid 50,470 median. A mental health nurse makes at least 52,000, and a nurse in the medical department makes $66,000. So the part of this problem is because the mental health field is not strongly organized, is not strongly acknowledged by the medical department. And this is a graph showing the increase in salary for mental health workers.
An alternative solution proposed would be to pass legislation similar to the Mental Health Systems Act of 1980, which would provide grants for mental health institutions to become more effective in serving the mental health needs of the community. However, the faults in this alternative solution is that it was repealed very early in 1981 during the beginning of President Reagan's presidency, therefore it could never have been effectively implemented, and the President's Commission on Mental Health were not experts in their fields, rather they were simply advocates.
So some strength to our solution is that more awareness has been brought to this issue, and one of the acts taken by SAMHSA is to execute the Partners for Recovery Act, and that required the Advanced Leadership Institute to train 28 leaders nationwide to better their skills in their jobs by improving their communications between their subordinates and their patients. The School for Prevention Leadership professionalizes substance abuse workers by giving them a trial and error on